We'd like to again welcome everyone to Nationwide Children's Hospitals for this, our fourth task force meeting. Our last meeting was, in fact, a very, very productive meeting. We accomplished a lot. We learned how important women's health is before she gets pregnant as a factor for birth outcomes. Lots of critical information that we touched on. Through our table exercises, we identified ways in which various sectors of our community can work to improve women's preconception health, such as educating our entire community about its importance to begin with, making sure that uninsured women get connected to the expanded Medicaid program or other newly available insurance options, and supporting efforts to ensure that physician payment policies incentivize improved preconception health. We also heard from the remarkable Sarah Brown about how reducing unplanned and teen pregnancies needs to be a central component of our plan here to reduce infant mortality. Sarah framed the issue in a couple of ways that really resonated with me, and I know with a number of you from conversations. First, women and teens whose pregnancies are unplanned obviously are at higher risk of poor birth outcomes. By definition, if we reduce the numbers of unplanned pregnancies, we can reduce the overall risk and the outcome of infant mortality. Secondly, we need to think about teen pregnancy more broadly. It's a barrier to broader community goals around educational attainment and economic self-sufficiency as a whole. The data showed that teens who get pregnant are less likely to finish high school, face more difficulty getting jobs than many of their counterparts. We need to be thoughtful in this approach, and we all know this is an area that, in fact, we can make inroads. You all came up in our work groups with some great ideas. We've recorded them. Ideas on the way this community can address the issue during those discussions. We're going to continue that process of discovery today. You guys really did a marvelous job in those discussion groups, so we've come to the realization that we want to hear more from you. So with that, Donna?
Yeah, please. So we're about a little over halfway through the process, and there's a lot going on even outside of these meetings. The staff has put together quite a few focus groups. They're already underway. We're getting lots of requests for speaking at various board meetings, and that's occurring at a fast pace. Dr. Long was commenting this morning that if we could just get rid of the mumps, she'd have more time to devote to it's very serious, so we're glad you are addressing the mumps first and this second. We've got enough issues on our hands, so thank you for all that preventive work, and to all of those who've been participating in getting the word out and getting the education out about the work that we're doing. In addition to meetings with Jesse and Julie, you guys are having as task force members around potential recommendations that we're going to be leading into. President Council Ginther and Michael and I will be calling each of you. We've sort of divvied you up, so we hope none of you get jealous because I got some folks and I couldn't talk to all of you. I had to share you with these two guys. So forgive me for not being able to touch base with all of you, but we want to make sure we have some one-on-one time with each of you as task force members as we're at this halfway mark, and to make sure we're getting the best out of you and what you have to offer, because sometimes this forum is not always the best place to do that because you're thinking and you're absorbing a lot of information. We also want to remind you that there are community meetings and forums underway. We have already scheduled 5 focused workshops with stakeholders as frontline providers, educators, social support organizations, faith leaders. 3 more are under development, and so we're encouraging you as task force members to sign up for one or more of those, because that's the way we are able to garner all of the good information and feedback from all the community stakeholders in this process. Let's see. All of the meetings are listed in tab 4 in your binders, and they're also posted on the task force website. Why don't I turn this over to President Ginther to add a few words before we get started this morning.
Thank you, Donna, and thank you all again for your commitment to this process. I do want to acknowledge a few folks, and I was hoping that Commissioner O'Grady would be in the room when I thanked him, but I want to thank Commissioner O'Grady, Commissioner Brown, and Commissioner Brooks. We've just learned this week that they are going to be investing and financially supporting the work of the task force, as well as providing some in-kind support. So they're joining, obviously, the City of Columbus, the Columbus Foundation, but then many of you around the room have also provided additional in-kind resources and support. Rayanne from Radio 1, Michael in the Dispatch and WBNS, and obviously Nationwide Children's Hospital and Columbus Public Health with staffing and support during this process. So I just wanted to thank you all for that, but also to reinforce Donna's point, if there are groups and associations that you might be connected with or part of, we are going to be spending a significant amount of time, all of us, in the next couple of months, reaching out to different folks in the community. So even if it's a group, I'm going to talk to the Columbus Chamber Government Day. They're probably not expecting me to focus on infant mortality, but I fully intend to, and talk to them about the business case and why this is impacting the economic development in this community. So even if they're not natural fits that come to mind naturally, keep those front of mind, and please thank a commissioner when you see them for their support of this work. Thank you.
No, thank you, Councilman. All that's very good news. The money, the support, and all the brain power and heart we can bring to this will be very helpful. So the focus of today's meeting, healthy pregnancy. If you take a look at the agenda behind tab 1, you'll see we're going to cover 3 topics today. First, Dr. Mary Ellen Wewers will share her insight about how we can address smoking as a key part of our plan to reduce infant mortality. I was really struck last week, and I hope I don't butcher his name, Dr. Fanai, when he pointed out that maternal smoking is a leading risk factor for prematurity and sleep-related infant deaths. That really caught my attention. You see the commercials about smoking, you hear about smoking, but to have that direct correlation to infant mortality and sleep-related infant deaths, which we all seem to focus on, was an aha moment for me. And I see some of you shaking your heads. It was an aha moment for you, too. So the secondary effect of smoke is something, at least I'm learning more and more about every day, unfortunately. And following that presentation, Dr. Kelly Kelleher will be interviewing Dr. Arden Handler, who will highlight the importance of prenatal care as a factor for infant mortality. So that's another term we're hearing on and on again, is prenatal care. We're going to overuse it, but apparently we're not doing enough of it. At the conclusion of the interview segment, we'll complete a table exercise. I'll be focused on developing recommendations around these 2 areas, but if there are other areas you still have in the back of your mind, don't hesitate to add those and get them in the record, even though this is our area of focus for today. And finally, close to close out the meeting, Dr. Mark Chaffin will discuss ways in which home visiting programs can be incorporated and optimized as a key component of our community. I think many of you in this room are aware we have those programs, but the whole notion of optimization and coordination, I think, will be key to that conversation. So without further ado, let's get started. Dr. Mary Ellen Wewers is what we would consider one of our local national experts and champions. She is a professor at The Ohio State University College of Public Health and a nationally recognized expert in tobacco control. She has published over 120 papers in the area of tobacco control. She is the co-principal investigator for the Ohio State University Center for Excellence in Regulatory Tobacco Science. Thank you.
Well, good morning, everyone, and thank you so much for this opportunity to speak to the group, and especially to speak about something that I care so deeply about, and to thank you again for taking this task force on and the good work you're doing. So I will get started. Hopefully. Keep going? Okay, here we go. So we're going to talk about perinatal smoking and how this is related, as you've already nicely mentioned, to infant mortality. So as you've alluded to, there are significant health and economic consequences that are attributable to smoking. I've listed here some of the common ones: preterm related deaths, preterm delivery, low birth weight, sudden infant death syndrome, and as well there are economic consequences: the increased admission to neonatal intensive care units and the extended length of hospitalization. So as has already been mentioned, smoking during pregnancy is one of the most preventable causes of infant morbidity and mortality. I just wanted to quickly mention, you have this in your materials, but we know that before pregnancy, about 31% of women in Ohio and here in Franklin County report smoking. About 21% report smoking during the last 3 months of their pregnancy, and then about 21% afterwards. I wanted to mention overall what a problem this is. About 70% of smokers in the United States want to be non-smokers. They want to quit smoking. About 42% will make a serious attempt to quit every year. So people want to be non-smokers. Unfortunately, this behavior, this dependence, this addiction results in only about 4 or 5% of adults being able to quit smoking every year. So it is a significant dependence and addictive behavior. The other point I want to make now, and I want to come back to it when we end this presentation, is that there is a significant relationship between education and the ability to quit. Generally, youth, advantaged and disadvantaged youth, start at similar rates. They adopt the behavior similarly. But as people go on to gain more material resources and have better opportunities in the work environment, their jobs, their access to health care, and their types of occupations, those are the people who then are much more successful at quitting. And I want to come back to that because there is a significant disparity between those who continue to smoke and those who are able to quit. Dr. Robbins, my friend and my colleague, Jesse, have asked me to talk about the essential elements that go into tobacco control. And it's really much more than smoking during pregnancy. It's really a larger social issue. So I'm going to talk some about clinical elements, economic elements, regulatory elements, and then the much more comprehensive elements. I do have educational elements up here, and by this we generally have met the school-based programs that have been now studied for something like 30 years. And unfortunately, school-based programs, that is, taking children in elementary school and beginning to teach them about the dangers of smoking, and the data and the evidence suggests that this does not have a large impact. that there are so many powerful forces as children reach adolescence that counter anything that was taught in school. So I want to mention education. It is important, but the data so far does not support that it's a panacea. I want to spend a little time on clinical elements, and I'll go there next. So this is information from the U.S. Public Health Service's latest clinical practice guideline and update. And I had the opportunity to participate on that panel, and we evaluated the literature that is available. And unfortunately, there's not a lot of good literature available about clinical interventions during pregnancy. But I wanted to talk in terms of counseling and pharmacotherapy. The span or the reach of this approach is somewhat small, and the impact to date has been somewhat small too. But what we need to continue to do as healthcare providers is to incorporate in our practices a clinic or a systems-based approach. And this involves attention to smoking during the prenatal and the postnatal or post-delivery period. Recommendations from the panel are to systematize identification of smokers. This can be problematic because there is stigma associated with smoking during pregnancy, and women tend to underreport their smoking status. There are very inexpensive ways to assess smoking status. We're used to providing urine samples during the clinic visit. If a woman is in care, then we are able to already test for glucose, proteins in the urine. There are inexpensive ways to incorporate into practices the ability to test for one of the major metabolites of nicotine, and that is cotinine. So that is an approach that should be considered. Clinic-based tobacco-dependent treatment via a nurse or a provider that takes responsibility for delivering tobacco dependence treatment has been shown to be effective. This is probably the best approach. I had the opportunity to work with Dr. Jay Imes, who's here in the past, as well as Dr. Judy Groner at Nationwide Children's and Columbus Public Health. We were able to demonstrate in research studies that having a dedicated tobacco dependence treatment specialist who sees the pregnant woman and discusses and provides behavioral counseling preterm, as well as a home nurse who delivers care post-delivery, those types of programs are effective. One thing I want to quickly mention when we were talking about this, providers have been encouraging women to cut down, if they can't quit, to at least cut down on their smoking. One of the problems with this is that the behavior, the smoker has smoked for many, many years, is used to a particular level of nicotine. And even though we're encouraging people to cut down, the smoker's brain is able to really sense what the amount of nicotine is in the brain, so they smoke their cigarette differently. If they're smoking fewer cigarettes, they're taking in a deeper breath. They're holding the breath longer. They're smoking further down on the rod. So they are really able to achieve the same exposures or the same levels of nicotine and carcinogens, carbon monoxide, that they've done when they've smoked more cigarettes. So this is an important piece of information. The other thing we can do is we can take much more advantage of our Ohio Quit line. This is available. There are special programs for pregnant smokers, and we need to be referring and taking advantage of the Quit line. I just want to say, in terms of pharmacotherapy or drugs, the evidence is inconclusive. There have been very few studies in this area of whether giving medication to pregnant women is safe and whether it's effective. So the latest Cochrane review, which is a systematic review of studies that have looked at drugs to be used during pregnancy, to date are inconclusive. The final point I want to make about clinical elements, smoking cessation, tobacco dependence treatment is reimbursable, and providers can bill for tobacco dependence treatment. This is not known by a lot of healthcare providers, so there are mechanisms to consider, and reimbursement is available. That's really what I want to say about clinical elements, because I want to talk about the broader community approach to tobacco control. I'm sorry, I did want to mention these three variables. If these factors are operating, it's much harder for the pregnant woman to quit. If she's highly dependent, if there is a history of depression, and if there is alcohol and other drug use, it's much, much more difficult and requires much more intensive approaches. I'm going now to this slide because many of you know this is the 50th anniversary of the Surgeon General's report. You can see at the top of the slide, top of the curve there, that's when the first Surgeon General's report was released. That was 50 years ago in January. And you can see now that cigarette consumption is coming down. And the only point I want to make of this slide is that cigarette consumption is coming down in the United States because the social norms about smoking have changed. And what has been successful from a public health perspective is the much broader population-based approaches. In 1964, half of the adult men in this room would have been smokers. About a third of the women would have been smokers. That's coming down now to where about 1 in 5 adults in the United States smoke. But there are serious disparities between who continues to smoke. And what I want to say now and talk about now is what are the population approaches we can use. So regulatory elements are important. The reach of bans on advertising about tobacco is very large. The impact is very large. Indoor air bans, the reach is large, the impact is large. Adolescents, teenagers, young adults are very susceptible to ads about tobacco. Movies, stars who smoke, make a big impression on adolescents. So anything we can do to regulate advertising and to enforce indoor, and now in some places like the Ohio State University and nationwide children's outdoor bans are important too. So this is just data that shows you prior to this release of the Surgeon General's report, there was not segmentation in terms of ads. The industry targeted men and women alike. But in the late 1960s, there was targeted advertisements to women. And you can see from this curve that on the right side, the billions of dollars that were spent on advertising, left side, the initiation rates. And that there was specific targeting to women with no college. There was separation, and it seemed to be that ads are much more effective in women who did not attend college. We know today that the annual cigarette company advertising in the United States is about $8 billion. That's about $23 million a day. That's about, if you look at just smokers, that's about $2 for every smoker in the United States. And the biggest approach to tobacco advertising is at the point of sale. And we know, we have very good data that low-income neighborhoods have much more advertising as compared to more affluent neighborhoods. So there are opportunities to do a better job in regulating the product here in Columbus. The woman on your left, I don't know with the lights if you can see her, this is a woman, part of the Winston No Bull campaign. This is a campaign that is targeted toward Caucasian women who attend NASCAR events. On the right, your right side is what's called a power wall, And this is what you see when you go to a tobacco retail store or any convenience store. These are strongly associated with impulse buying. So even if people are trying to quit smoking, and we know most people are interested in quitting, these power walls are very effective in prompting impulse purchases. You've probably all seen the Newport ads, which are menthol products and are targeted to our African American smokers. And then again on the right is the No Bull campaign, and again, at least you can still smoke in your car. So again, it's to the NASCAR circuit. So advertising is critical, and restrictions on advertising are critical. Want to talk about the economic element that's timely here in Columbus. We know that taxation, the reach or the span is very large. We also know that the impact is very large. There is good data that younger smokers are more price sensitive than adults, so they are more responsive to increasing taxes. And as a general rule of thumb, we know that for every 10% that we increase taxes, there will be a 1% drop in the prevalence. So that's something we should be considering as we move forward with taxation. We also have information about how the public feels about taxation. There is research published in JAMA that the majority of voters will support a tobacco tax if the funds are directed towards medical and public health research, and if the campaign is focused on preventing youth from initiating the behavior. So campaigns that are related to tobacco taxation should consider these factors. We also know that states, from the National Cancer Institute, we know that states that have a high excise tax actually do have increased state funding for cancer research, and this is an important consequence of tobacco. So that information is also published. But I want to end with what can we do comprehensively. California has been the leader in approaching tobacco control, and the way they have done it is through the incorporation of these strategies or these recommendations. It's been about changing the social norms, and changing the social norms helps to bring the entire population along. So some specific recommendations are to protect from exposure to secondhand smoke. This involves clean air ordinances, indoor, as well as thinking about some outdoor parks, recreation areas, things like that. Restricting advertising and marketing, and to counter with counter-marketing and mass media approaches. We in the state in the past have had a mass media program. Unfortunately, some of those funds have gone away, but we were seeing important improvements in rates of smoking among adolescents, that they were dropping when we have mass media type approaches. We have to continue to work hard to reduce youth access, especially around schools. There are some restrictions from the Master Settlement Agreement that where tobacco outlets can be in relation to schools, but we know that these aren't always enforced as they should be. And then continuing to provide treatment to our smokers is important. There are the quit line, there are opportunities for Medicaid enrollees to access the quit line, so we have to continue the efforts in that regard. And then finally, increasing tobacco taxes. So I want to just finish with the health impact pyramid. You may be familiar with this pyramid that was actually developed in a paper written by Thomas Frieden, who is the director of the Centers for Disease Control Prevention. And you see an arrow on the left that as you go down the pyramid, you increase the population impact. On the right side, going up the pyramid increases the individual efforts that are needed. But if we think about the bottom of the pyramid and we think about the disparity and the socioeconomic factors that really influence smoking, again, think of it as a disparity. Think of good tobacco policy as good social policy. We talked a little bit about keeping women in the educational system, reducing the age of first pregnancy, reducing being able to keep women in the workforce, have employment opportunities, job opportunities. This will affect the population significantly. The second level is changing the context for people to make healthy decisions by default. And the more we can do to keep the normative behavior and such that people are not exposed to tobacco ads, are not exposed to secondhand smoke. As long as we can keep these regulatory and comprehensive and economic elements part of our default decisions, the more we will be able to reduce tobacco control, tobacco prevalence. And really, when you think about it, the woman, we have to go more upstream. We have to think about the woman when she's a young woman and keeping her from ever starting smoking, because you've seen the data how hard it is to quit. So in summary, just 2 slides. There are multiple approaches that we need to be thinking about. Clinical elements will impact primarily at the individual level. The economic, the regulatory, and the comprehensive elements will impact at the population level. And in summary, what reduces consumption, their population-wide public policies, the bans, the taxation, the tobacco-free environments, and I've left you with the graphic warning label. I apologize. It's not pretty, and they're not available here in the United States, but other countries that have used graphic warnings have found that they make a significant impact when they're on the product. So with that, I will end, and thank you again for the opportunity to speak to you.
Thank you, Dr. Wiewers. You've given us a lot to think about. I sit here and I think about all the elements of this challenge that we've talked about to date. And unlike so many health issues, there are answers to this, changing the infant mortality issue in this community, and we know what the answers are. It's multifaceted, and this is just one piece of it. So it's important that we focus on this as well. So we'll have time to process some of these thoughts and work directly with Dr. Wiewers to think through some recommendations on smoking during the upcoming table exercises. But before I move to that, I'd like to just acknowledge Commissioner O'Grady, who had another appointment earlier. We appreciate your being here. Council President Ginther acknowledged our appreciation for the support of you personally and the support of your fellow commissioners. So thanks very much for helping us move this effort along. So before we move into our groups, we have our own Dr. Kelly Kelleher, Vice President of Community Health and Research Services, Research Director in the Center for Innovation and Pediatric Practice at the Research Institute here at Nationwide Children's Hospital. And he is going to conduct an interview with Dr. Arden Handler. Dr. Handler is a recognized national expert on infant mortality with a particular expertise in prenatal care. Her research is focused on identifying and addressing factors that increase risks for adverse pregnancy outcomes. Dr. Handler is on the faculty of the University of Illinois Chicago School of Public Health and is currently a member of the National Secretary's Advisory Committee on Infant Mortality. Dr. Kelleher.
Thank you. I hope everybody can see okay. The chairs are a little low, but
I'm short.
Okay. But I had to sit below Dr. Allen's chair over here, so I just want to make sure. Dr. Handler, thank you for coming. Before we start, I want to ask the task force, remind them of 2 things. First, behind tab 2, you do have some slides from Dr. Handler for background information. But the second thing, and more importantly for this morning, is that this will hopefully be a group interview. I'll start with some questions, but that really be excellent for the task force members to be engaged and ask their own questions, so we'll try to be attuned to that.
Okay,
Thank
thank
you.
you. Well, thank you. I just want to thank you for inviting me and for giving me this opportunity. Prenatal care is my thing, and I'm so passionate about it, and don't often have a chance to talk about it because it's somehow people are just not addressing this issue as much as preconception and women health care right now.
Well, why don't you start with that? Tell us why early prenatal care is so critical to infant mortality reduction here in Columbus.
Okay, well, first of all, I want to start by also saying that I think, you know, we just heard about socioeconomic factors and the importance of reducing poverty and providing access for not only health care but to opportunity, and I think probably that's most fundamental. But regardless of whether we can get that figured out, not having like an absolutely excellent prenatal care delivery system in a country like ours is, to me, very egregious. Early prenatal care really makes a tremendous difference because even though, you know, we know that women health care is absolutely fundamental, and you learned that last time, women need to walk into pregnancy healthy. But if they don't, we have an opportunity to identify risks. We have an opportunity to change behaviors, as we just learned about smoking, as well as other behaviors, and we also have an opportunity to intervene. And so and also to provide social support and critical linkages to other services and supports such as case management, family case management, nutrition in the WIC program. And if women come into prenatal care late, a lot of those opportunities are missed, and what we're doing is we're playing catch up toward the end of the pregnancy when it may be too late to prevent a preterm delivery.
So early engagement is important, but I think most of our community would agree all those things are important. Nutrition, social support. You know, it's a lot of work though. How do we ensure quality in the process?
Well, I think that that's really one of our biggest challenges because we have spent our entire public health lives counting visits. And the way we measure, quality is sort of this idea of, first trimester entry as well as adequacy, and we don't have good standardized measures of what is quality prenatal care. And we know that there are many good components. We know what they should be, and many efforts have gone into what should happen at the first visit, what should happen at the subsequent visits, what should be the lab tests, what should be the health promotion and education. But we don't hold anyone accountable for those. And so what we say in Chicago, we have what we call doc in the boxes, where there's lots of storefront providers who we know are not delivering a high quality care. As women move into more and more organized settings of care in FQHCs and health departments and outpatient clinics, there's more opportunity, we know, for a structure around what's delivered. There are also new approaches being considered. How do we, first of all, we have to measure, but we also have to consider that, some new models, and people are talking about and testing centering pregnancy, which is a group prenatal care model. You may have heard about it. The nation is interested, and so there's the Strong Start Initiative, which is testing this model, but it's now proliferating all over the country, where women go through the prenatal care process as a cohort, and a lot of the social support and health education, health promotion activities happen together as a group. There's other models, such as maternity care homes, where it's very difficult for I think part of the problem, it's sort of like schools. Providers of prenatal care are asked to do everything, solve all the problems that a woman walks in with, and they're asked to not only address the smoking, but the substance abuse and the domestic violence and the interpersonal issues and HIV, et cetera, and the checklist, and everybody wants their thing done. The checklist goes on and on, so we have to give providers new tools to do that. Some places are using a more integrated approach where on one sheet the provider can ask all the questions and get at all these risks. There's other approaches where you ensure that there's incentives for the risk assessment and then payment incentives for the appropriate referrals. Connecting, North Carolina is experimenting with a model where their practices, OBs sign up to be part of a practice, and then the family case management care coordination entity is another entity that comes in and is attached to the practice and helps the provider provide that support. So it's because we're expecting a lot from physicians who are very, very busy, and we know in this era of managed care may only have 5 minutes with a woman. And additionally, one other thought is to be using midwives who do have historically more time to spend with women, and to do more of that. That's very much a model in Western Europe.
So, just to summarize then,
I'm sorry, I could go on and on.
Yeah, it's exciting. I just want to
Okay.
make sure I capture it
Yeah.
all. So number one are some different models, group or social modeling, centering and the like
Centering is
programs.
one.
There are also case managers and activities that surround some of the practices and accountability measures that can be built in, and
Exactly.
checklists,
And incentives.
and then incentives.
Right.
Great.
And that's just sort of a tip of the iceberg. But I think in general, quality is one of those unknowns. We just have not paid significant enough attention to it, and it's just really hard. Even prenatal care researchers have trouble doing quality studies because for every woman there's going to be a different set of risks, and it's really hard to measure what's quality care for this woman. So if we at least have some sentinel measures, every woman gets X, Y, Z, and we report that on a regular basis, and I think the Medicaid program could encourage that and make sure that there are incentives for that. I think we'd be going a long way.
That's great. So, but all that's contingent on the women getting there early.
Yes.
In our community, we don't do very well with that.
Yeah.
Only 60% of our African American women and 70% overall even get to early prenatal care. Where do you start with that?
Well, just so you know, you're not alone. This is pretty much a nationwide problem. We had been historically looking at numbers more like 83 to 90%, and with the new birth certificate, we're finding it's more like 60 for African American women and 70 for European American women. And I think that there's so many issues. One is that we don't value pregnant women, and we certainly don't value low-income pregnant women. We kind of think they're a problem. So if we begin to think about valuing, sort of a more women-centered approach, that if you're pregnant, we're going to love you, we're not going to look down on you. In California, they adopted in the African American Healthy Mothers Project something called 100 Acts of Kindness, where if you're pregnant, they're asking women, women are asking, don't touch my belly, give me a seat on the bus, respect me, feed me, take care of my kids, hold my package. The whole idea that that we want to support you if you're pregnant, and I think people are afraid of that because they feel like, okay, does that mean we're encouraging women to get pregnant? So there's this constant tension between that and all the other politics around pregnancy. But we do want to say, once you're pregnant, we love you, embrace you, come in. And I think if we make these programs more universal, and it's not just targeted at low-income women, and that we understand that's the standard for all of Columbus, for example, and this is what we're doing in Columbus for all pregnant women, there's more of an opportunity for women to say, oh, I'm pregnant, I'm valued, I'm important, I'm going to get a free bus pass, I'm going to be able to get a coupon to go to Target, or whatever it is that we do. Years ago in Chicago, we did something healthy, it was called Beautiful Babies, where every pregnant woman, not just low-income pregnant women, got coupons for being, when they're pregnant, which gives you the idea of valuing women. So that's one thing. The other is we typically don't do good outreach. So we do have case management programs. So once we find you, we are able to case manage you, but we have a hard time finding. Even in Chicago, where we've had case management and Healthy Start projects forever, we don't do outreach. So women are entering care late, and the whole opportunity for the first trimester is missed. And so we did try a concerted outreach campaign once with Healthy Births for Healthy Babies, and seemed to make a difference, but it really takes effort, and you have to have funds to go toward that. The other thing is this whole idea of women knowing that for women who are not typically on Medicaid already, so the poorest women are already on Medicaid, and their issues are more about social issues and not being valued and not walking into prenatal care because of other factors, right? They may have too many kids to take on a bus, or the clinic says no strollers allowed. And we're not family friendly. I mean, in Chicago, I once walked into a clinic where literally it's a prenatal care clinic, and there's a sign, no strollers allowed. So what do you do with your 2-year-old and your 1-year-old while you're there for prenatal care?
Yeah.
We also, I don't know if you have a problem here with block appointments, but everybody got an 8 o'clock appointment, so you could sit there all day long.
Right.
So those kind of changes to make it easier for women, but also with the Medicaid expansion for women who are not typically eligible for Medicaid, if they are now eligible because they're pregnant, most communities don't let women know about that. So typically the hospitals get reimbursed for delivery, but the woman never got to take the advantage of the Medicaid reimbursement, knowing, oh, I'm actually covered during pregnancy. I can go in now. So we don't educate women. We don't want to spend the 50 cents to get the dollar back from that kind of thing.
Yep.
So we really need to tell women, if you're pregnant, it's likely you're covered, come in.
Yeah. So I'm going to keep
open-
pursuing, but
yeah,
I want to
whatever.
make sure that if there's any questions that they come up from the task force
Yeah, and I
members,
see
so-
some nodding heads, so please feel
Yeah.
free to just
Yeah.
interrupt. Yeah.
Yeah.
Struck by your,
Where's the person speaking?
I'm right here.
Oh, okay, okay. Sitting back here.
I'm struck by the slide that says we should focus on empowering women and increasing their voice in prenatal care. Could you comment on that?
Yeah, I mean, I think there's a real sense of that, you know, this is still a medical, prenatal care is still a medical process, and really it's about social support and women feeling control of their lives and their reproductive health, and prenatal care is one other aspect of, you know, reproductive health. And so the interventions that I think one of the interventions that goes furthest toward empowering women is the centering pregnancy model, where women are together with other women and really talking about their needs, and the health education, health promotion is really directed. I mean, there's some structure in terms of moving along the pregnancy and what you should be addressing, but really meeting women where they're at. And a lot of times when we have an idea, well, women should get this, when really what they're thinking about is feeding their other child, or, you know, we tend to not really meet women where they're at, and we have this idea, you know, we want to make sure that they get this, and that, when they can't get those things until they get that thing taken care of, and that's really critical. Oh, it's hard to hear you.
Oh, I'm sorry.
Okay.
Oh, is that better?
Yes,
Yeah.
yes.
Okay. Two things. One, can you talk about any successful outreach, perhaps in Chicago or North Carolina or California, in which we engage fathers, mates, families around early education on prenatal care? And two, beyond funding and some of the examples you gave us regarding Medicaid, can you talk a little bit about bridging the policy with practice, like what in legislation or what kind of public policy requests or asks can we perhaps rally around and build more public support so that we can go to legislators and say this would increase access, this would increase education for prenatal care?
Okay, well, the first about fathers, I mean, there's definitely a movement to want to include more men in the process, but I would say I think it's very fledgling and beginning. I mean, there's definitely in the Healthy Start programs, I know there's definitely an interest in this, and I know from my friend Fleda Jackson in Atlanta, there's been projects, but I actually have not seen data or evidence about paternal involvement. We do know that, right, we tend to think about this as a woman's responsibility, and unfortunately, too many women are on their own during this process, and there is a great need to engage families, and not just fathers, but all families, and family support and is critical, and for women to go through the process successfully. In terms of legislation and change, it's hard for me to to respond to that exactly, because I don't know your system as well as I need to know it in Ohio, and a lot of it really is driven by the provider community coming together to say, we want to introduce standards, we want to make sure every provider is doing this. I'm not sure we need legislation for that. It's almost like we need best practices with leadership from the provider community, and in conjunction for low-income women with the Medicaid community. But I think it's the kind of thing, if ultimately we wanted those standards in private insurance, we would have to probably go to the legislature for that kind of thing. Other policy changes, I mean, if we wanted to spend, I guess, funding on, sort of a universal access to prenatal care campaign, and the kinds of things where, like the Beautiful Babies Initiative, those would need funding support, and so the legislature would have to give money to the Department of Public Health to do that kind of work. There's so many things. I'm not quite sure how to respond, because there's like so many pieces of this. And so I probably would do better with more targeted, like, if we want to think about a specific aspect of prenatal care in terms of getting women early, or we want to talk about quality, or we want to talk about transition from prenatal care to delivery and to postpartum care. There's a lot to be done. The other thing that's really, I think, critical is sort of the idea that it's a system. So we tend to isolate prenatal care, and we tend not to think about the connections between the Well Woman Health Care primary care system and the prenatal care delivery system. And I know in Chicago we have the situation where a lot of OBs don't then connect women back to medical care homes. And so one thing to think about is the whole notion of a medical care home, and then within that, do we want separate maternity care homes, or is the medical care home sort of the hub? And there's sometimes a maternity care home, that's a very tricky issue, because if you go from your primary care provider to the OB, do you get hooked back into the primary care system? You know, what is the system that you're going through? We're definitely struggling with that in Illinois, trying to figure out the transitions between all the pieces. And that's something I think that legislators could take a look at, sort of the system connectedness and what the handoffs should be and how we make sure women get from place to place, essentially. Oh, and in addition, we have had legislation in Illinois for family case management, not enough, and for high-risk prenatal case management. That's come from our legislators in Springfield to mandate that those kind of programs exist.
Could you say what the health homes, maternity homes are in a little more detail for people? Just
Yes. Okay. So we've all heard a lot of talk, I think, with the ACA about medical care home. The idea that you're not just on your own floating from physician to physician, which I think is not a great system. So we do want everyone to have a medical care home where someone's sort of directing the care. There's this notion that women should also have what's a maternity care home, where so you're not just going for prenatal care and then you're not connected to other systems, but that the provider is connected to a larger system of social supports, case management, WIC, if there's a healthy start, and that maternity care home tracks you and sends your information to the hospital at the right time and back to your primary care provider, and is making sure that you're just not on your own, coming in when, you know, but not recognizing if you miss 3 visits, that some home visitor should come to see you. And in North Carolina, the way they're doing it is that you sign up to be a maternity care home.
Yes.
Not every patient is necessarily going to receive all the services, but then there's case management or care coordinators attached to that maternity care home who are taking a look at the highest risk women and trying to make sure they get all these supports. Okay.
One other follow-up question.
Yeah.
So, and just to build on your comments, what about reaching out to women who are in non-traditional type of treatment settings? So, for example, women who are incarcerated, women who are in shelters or temporary housing situations, residential treatment. What kind of coordinated efforts are we experiencing or even trying to be able to reach out to them?
Yeah, I think we're not doing a very good job there. And I think that that's definitely an area of interest and importance, and those women are going to come back out to the system. And I think substance abuse in general, we had a big emphasis on it in the 90s with crack babies, and we were obsessively compulsing about crack babies when we actually had bigger alcohol problems. And we spent a lot of time talking about treatment, and now I think it's a hidden problem and we don't do it enough. And as our prior speaker talked about smoking, I mean, we really need to have, you know, good screening for substance abuse. I think the other problem with that is that providers are not sure what to do. So it's one of those issues that they're not very excited about digging deep, and they don't really want to, you know, find out if they don't know what to do, and they don't feel that supported. And similarly with depression, there's not really necessarily good mental health resources. There was a really exciting project that was going on in Illinois for a while, where the recognition that we didn't have mental health capacity, but we had a lot of depression, and so there was this, not just a quit line for women, but providers could call and say, I have a depressed pregnant woman, I cannot get her into mental health services. What medications can I give? What's safe? So the University of Illinois psychiatrists were providing doctors with information about what was safe at different trimesters. So that was, I thought, a fabulous way to you know, not have to refer a woman out, and to provide support for the provider who cannot be an expert in everything. I mean, OB-GYNs are not internal medicine docs, and they're not psychiatrists, and they have to deal with infections and cardiovascular disease and hypertension, and guess what? They weren't really trained in those things. And so it's really complicated when you have high-risk women, socially high risk, who then often are medically high risk, when the provider is an expert in a lot of things, but the kinds of things we're tasking them with, they're not experts with necessarily, and they need partners and need collaborators, and they don't often have that, and they feel isolated.
Yes.
And it's a hard road to hoe, you know. Yes.
As
So great stuff. I really think that you've really broadened our understanding of what goes into prenatal care. My question, though, is what's the expected treatment effect?
Of prenatal care, efficacy?
If you do if we do most the stuff that you say, what kind of decrease could we expect on infant mortality?
Okay,
rates?
well, this is the tricky part because the studies of prenatal care have historically shown, I would say mediocre effect. But we have had historically huge selection bias in those studies, and it's been problematic. I think we've gotten much better in our analyses and are beginning to finally adjust for the selection biases. The maternal and child health researchers have finally hooked up with the economists and are bringing those kind of methods into the research. So I think there's enough evidence to suggest that enhanced prenatal care, Kay Johnson would say, doesn't make a difference. Lorraine Cameron did a randomized control trial and she found it didn't make a difference. I look at the research and you can see from the article I sent, I don't know if everyone got it, that it showed for sure that in low-risk states, we do have an effect of enhanced prenatal care, which means not just regular medical care, but bringing other services into the care. We also have some evidence from a series of studies from using vital statistics data that this was from Vince Leos, it's a hard name to say, that prenatal care seemed to make a difference in preterm delivery for singletons and preterms. This is more recent. I mean, there's also, I think part of the problem with the whole prenatal care literature is that it's all been based on visits. So we haven't had good, large population studies on quality. And so we really don't, you're asking a great question. I don't have, can't say to you, if we do this, this, and this, get women in early, have excellent prenatal care, that we're going to show these outcomes. Part of the problem is, too, we don't have a good way of measuring resolution of risk. So we know by the end what risk she had, and we have, a checklist, but we don't show that actually she came in, we resolved this risk, and she would have had X, but now she has Y. Nothing like that. So the literature is so complex. I have a doctoral student who I'm trying to force to do this kind of dissertation, like try to figure out who came in with this diagnosis, where it was resolved, and then what happened. I haven't seen one paper like that, the resolution of risk, and then what that means. So it may be a lot worse if we don't resolve risk. We don't really know. So that's, I think, one of the problems, too. I just go with, okay, that if... We know that management, we know that we've reduced fetal deaths for sure with maternal management, especially late in pregnancy. And so the preterm delivery issue is, again, very complex because we don't know what causes labor and then we don't know what causes preterm labor, but we also know that we have lots of potential areas where we haven't done enough. So we haven't done enough of an infection. We basically have abandoned bacterial vaginosis, for example, as some place to intervene because of one big, messy maternal fetal medicine trial that had a lot of problems and that's led to, residual, every time you do a Cochrane report, that trial comes up as the biggest trial. We don't have much going on chlamydia, which seems to be important, and we know it's pervasive. So we have a lot of areas where we know if we reduced infection, that, if we really handled infection, if we handled the diabetes, if we did something about the obesity, the depression, we have so many places to intervene, it seems to me we would make a difference. We just don't have good studies to show it because we study obesity only, infection only, stress only, and it's very difficult to study comprehensive prenatal care because women come into prenatal care with different risks at different times. And so it's just a very problematic literature. I just know that excellent health care during pregnancy, not only is it a social justice issue, it makes complete sense even for risks in the next pregnancy and for well-woman health care. Even if we couldn't figure out the 9 months and this delivery, how about the next time? Because then she's in the system with excellent connections, care, and we know what to do next round. So I wish I could say definitively, and I can't, but I feel like enough of the literature suggests that there are so many places that we could intervene. We just haven't had the methods really to look at it well enough. Sorry for that long-winded answer. I wish I could be more positive in that way. Yeah.
So we're going to move into our groups. Thank you, Dr. Handler, Dr.
Okay.
Kelleher. We appreciate your setting the stage.
That was very quick.
We also have 4 local experts who have graciously agreed to join our exercise this morning. They'll provide local insight and considerations for recommendations from different perspectives that you're going to discuss in your groups. It's my pleasure to welcome Dr. Sona Booker, manager of Ohio Health's Wellness on Wheels program, which takes prenatal care out into the community. Back here.
Raise your hand so they'll know who you are. Thank you.
Sana will provide insight into the patient perspective, highlighting some of the challenges for women in this community who need or who are seeking prenatal care. Dr. Ngozi Nswago, who's also with Ohio Health and is providing OBGYN affiliated with Doctors Hospital. Dr. Ngozi Oswago will provide the provider perspective and review some of the challenges that she and her colleagues face in providing prenatal care to low-income and to high-risk pregnant women in our community. Dr. Mary Applegate, the medical director for Ohio's Medicaid program, will discuss challenges and opportunities related to state-level policy for improving prenatal care. As well, finally, Dr. Weavers will also be a resource to help us think through potential community interventions for reducing smoking risks related to infant mortality. As usual, we've developed a set of questions that'll help you develop recommendations for these areas. We've asked the experts to make brief introductions in the groups and then serve as a resource for you to work through the questions. Similar to last time, we provided prenatal care and smoking resource guides to kind of inform your discussions. The document includes local data on key preconception health indicators in the community and insights about potential interventions from other areas in the community. Members of the public, we're going to look for your help again. You've also received packets that include the resource guides as well as the questions that we're considering. We encourage you to take a moment and to turn to your neighbors and discuss these issues with your resource guide there available. We ask you to record your responses and give them to either the co-chairs or to the staff to help us in this task force process. So lastly, due to time constraints, we're going to ask everyone, you have 4 topics. We'll ask you to concentrate realistically on 3 of them, and we're going to move our specialists around every 12 to 15 minutes. We're going to reconvene here in probably a half hour, 35 minutes or so. So with that, we'll break into our work groups.
So we're going to start with each group. Let's start with the smoking topic, and I'm going to say the smoking topic, but I know you guys are going to have kind of blended recommendations and ideas, but we'll try to stay as focused as possible. So let's first focus on the smoking topic, and let's start with the table where I was seated with Michelle and the Reverend and Dr. Allen. And who's going to report out? Will that be you? All right, thank you.
So I'm going to disappoint you and tell you that I don't think I can unblend this.
That's okay. Go ahead and disappoint.
Okay. We really had great discussion, and I'm going to talk about 4 specific things. One is looking at potential change in policy at the schools, which may allow our mobile wellness prenatal folks to dispense birth control, which they currently cannot. Right now, there has to be a handoff to another provider, and every time there's a handoff, there's a opportunity for falling between the cracks. The second is we really want to focus on holistic, comprehensive services. Those are key. So blending case management, social work, nutrition, with the medical pieces has shown to have really good results, and we think moving more closely to holistic care. Also looking at standardization of care across all populations for all clinics and all providers. We heard a lot about quality earlier and are really not being able to get a hold of it. There are some standardization tools or procedures that are available that we think should be pursued for all providers. And then expanding programs in our community that works, that have good track records, that have shown to decrease infant mortality, that are already in place that we may need to look at expansion.
Yep. Well, thank you. And I'm going to go to this table. If you can focus on smoking, great. If you have a blended response, that's okay as well.
One of the things that we were talking about in depth was the power of the tobacco lobby in terms of not being able to get on our tobacco products more graphic representation of just how harmful the whole smoking epidemic is. And the question becomes, how then can we become more forceful in combating that lobby to make sure that that kind of graphic representation gets done? The other concern that we raised was the concern about being able to get more educational opportunities into our community, particularly into our churches, so that women become more aware of how negative the whole smoking epidemic is. So these were two concerns that we had.
That's pretty pointed.
Yeah.
Thank you. And I'll also note, both of you have come up with recommendations that I think are both courageous,
Yes.
with, the consideration that we have to put behind that courage, whether it's relative to politics or different points of view. So thank you for adhering to courageous and considerate recommendations. Let's go to the table here where Dr. Long is seated.
And we had amazing conversations. We didn't get to talk about tobacco, so you won't hear about that from us, but we would like to, I think. But we learned about the new perinatal bundling of quality expectations that's across all payers, so not just Medicaid, but all of the 5 large commercial payers. And we're both excited to learn about that, but still left with the idea that we have to think about coordination, care coordination. And in the conversation connected to both Medicaid and other patients was that many of the women do not understand both their expectations of receiving prenatal care and the responsibilities that come with that. And so there was a recommendation that we need to consider, how do we inform women as they become Medicaid eligible and they go into prenatal care, how they can use what's available to them, but also what the providers and the other partners need and expect of them. We heard some poignant tales about what doesn't work. The other was learning about the young and not so young and some of the challenges around the social determinants of health. So as far as specifics, we heard about a very new initiative that Grant Hospital has just initiated, where they are personally visiting every woman who delivers, and in 3 weeks they've had 9 women who've delivered with no prenatal care. And so just in those 3 weeks, they've had specific outreach to them and tried to very much support them in their aftercare, both for themselves but also for the infants. And so we were just chatting about that would really be potentially something to look at across our system, but also we need to evaluate how well that works.
That's phenomenal. Great partnership and also a provider perspective in terms of opportunities there. Let's go to, have I missed a table? Yeah, back here.
And do you want to go on smoking, Donna?
Smoking, and if you have others, because I know sometimes it was hard to separate the conversation, that's quite all right.
I'll stick on smoking if that's the request. We didn't have policy, so I will balance you out, Dr. Long. And we didn't have an extensive time to discuss smoking, but 3 points. One would be, when creating a shift in social or environmental change, sometimes that's about towing the line that's already been in place. And we talked about e-cigarettes and what policies have or have not been adjusted, shifted, or been rewritten to account for the e-cigarettes and vapor. And I equated it to kind of like the Marlboro Cowboy from decades ago, that it's now the hip trend for women to have a vapor cigarette. So what's being done in a policy change there? And then number 2 would be going to the earlier demographic of, point of first use of tobacco. So where is the demographic age that we can continue to do the advertising? And, while we can't have some of the advertising on the packages about that other countries do, could we go to where the younger teenagers are, and YouTube ads, internet streaming, when you are forced to watch those ads, you cannot fast forward them. can there be those public health announcements and PSAs interwoven into the media messages that have to passively come into the eyes and construct of their environments? And then 3, on the prenatal intervention moment, the earlier the intervention of the conversation about tobacco cessation, that when that can happen, the more increased likelihood of success that pregnant mom will not continue smoking once the baby is born. So those are 3 moments: toe the line where we are, get them on the prevention side, and then the intervention on the prenatal.
I really like that concept of getting to young people, kind of meet them where they are in terms of the advertising. So there are a couple of other areas. I'm just going to throw this out to all the tables in case there are recommendations you have that we've missed. So we've started off with smoking. We've heard some on the provider perspective and around improving prenatal care. Any other recommendations under any of those topics? And I'm going to throw out a 4th one, Medicaid policy. Did any of you get to talk about Medicaid? I know you did. I see the heads nodding. Any aha moments that could either be a recommendation or even a question that you didn't get to fully discuss around Medicaid policy? Yes, Michelle.
I was excited as formerly a Medicaid provider that they're really looking at getting folks together to think about a holistic way of caring for women that do have all the things that folks need: the case management, some social work, the medical supportive groups, getting folks together culturally appropriately. And Medicaid is leading this both for private and Medicaid dollars, and that is a sea change. Looking at that holistically, and providers being able to bill for those services, which will then encourage them to provide the services and to have those relationships to bring it forward.
So I guess a question might be, and this may be for our Medicaid expert, if this is already in progress, are there things that we need to do or could do from a recommendation perspective to expedite or sort of seal that as an approach and be supportive of it? I forget, where's the, yes, Dr. Applegate. Why don't you take, yeah, there's Mike, thank you.
The conversation was anchored around our value-based purchasing for perinatal care and what that actually meant and what those opportunities were. There was a bit of discussion as well related to the possibility of doing a centering kind of approach where you take groups of women together, often who share minority status or a problem like opiate use or being a teenager. And then we really leverage the social support as a way to actually get to better outcomes. So we do think that with this change in how we pay for care, it will invite non-traditional partners. But I think this is a process, but certainly I do think it could accelerate that sort of change.
Yeah, that was an eye-opener to know that it's actually, you're starting down that process. I think we talked about the focus may be on clinical initially, but you've got to get the muscle, I call it, and the rhythm in place, and then you can add other issues or approaches beyond clinical.
We're planning to start that reporting so that the clinicians and hospitals know how we're doing with perinatal health and quality starting this November. So simply that transparency and reporting may be some of what will drive the change.
Perfect. Thank you. So we've heard a good amount on the smoking, tobacco lobby, how do we get to young people with education, the centering of women, and the Medicaid policies that are already in place. If you have notes that you've taken, I know you think no one can read them, at least that's how I look at my notes, but we have folks who really can decipher. If they can read my notes, they'll be able to read yours. So please, hang on to those and share them with the staff. Any other recommendations or points of interest that you want to raise? Good dialogue. We're going to take a break here. And then come back, and let's make this about a 10-minute break so we can try to get back on schedule, which would put us, don't look at that clock, I'm understanding that clock's a little slow, which would put us about at 11:10, 10 after 11. All right, thanks everyone.
It's my pleasure to introduce our final presenter this morning, Dr. Mark Chaffin, who's joining us from the great state of Oklahoma. Welcome. Dr. Chaffin is a professor in the Department of Pediatrics and Director of Research for the section of Developmental and Behavioral Pediatrics at the University of Oklahoma Health Sciences Center. His research focuses on developing, implementing, and scaling up evidence-based parenting programs, including clinic and home-based models. Dr. Chaffin will make a brief presentation on the role and potential opportunity to effectively utilize home visiting, which we've been talking about, as a component of our strategy to support both healthy pregnancies and thus improving birth outcomes. Please join me in welcoming Dr. Chaffin.
So we're connected. Can you guys hear me okay? Good. I'm pleased to be here on this somber occasion because, you know, last night my Sooners lost in the NCAA just like your Buckeyes did. So I was in Atlanta on my way flying here. And just as the plane was getting ready to leave, you know, the last seconds of the game were ticking down, and there was a crowd of Ohio State people collected at the bar across from the gate, you know, watching the TV. And in the last 3 seconds of the game, there was this big collective groan that went. So I was getting on the plane with all these people who were there shaking their heads, saying, "I can't believe it. I just can't. I can't. I can't." So, and then last night I had to watch the Oklahoma game and had exactly the same experience on this. My background is doing research with very high-risk populations, primarily parents who are in the child welfare system or who are at very high risk to be in the child welfare system, which kind of led me into research on home-based services and home visiting. Home visiting is a delivery modality. It is not a program. It's a place where services are delivered, and often these are maternal, infant, early childhood, health-oriented kinds of programs, and there's a lot of them. So when we're talking about this, you know, don't think about, well, I want this model or I want that model. You know, think of this as a platform, a place, and a modality by which a lot of the kind of services we're talking about can be delivered or can be facilitated. So home visiting is not necessarily a standalone thing. It is part of an integrated network of community services and maternal and child health services. By the way, it's one that's rapidly growing. A lot of people don't know this because it's sort of buried deep within the Affordable Care Act. But part of what the Affordable Care Act does is it funds what are called MCV, Maternal, Infant, Early Childhood Home Visiting Programs. These are in all 50 states. Many of these programs were in states before MCV, so there's both MCV funded and other programs. They're probably in your own, I'm pretty sure they're in your own community right now. So it may be there may be opportunities to leverage some of these programs and build or expand upon them to accomplish what you want to accomplish. Okay, quickly, just to kind of go, you know, I'm kind of being a researcher from the school that looks at what people sometimes call root cause analysis. What are the root causes of injury, serious injury, mortality, morbidity among young children? Well, there's two kinds. First, over here on the right, there's a handful of things that are specific causes. And these are things like sudden infant death syndrome, shaken baby, no car seat. Injuries, car wrecks are a big cause of infant mortality, or congenital malformations. But then there's this big group of non-specific things that are just, this is why infant mortality is not so much a single thing. It's, you know, in public health, we use it as a barometer as much as anything else. It's a barometer for the overall health and welfare of a neighborhood or a community or a society. So where you find sick and dying babies, you'll find moms who are not doing well. You'll find neighborhoods who are not doing well. It's a barometer for a whole lot of things. And these are the non-specific causes. Maternal health, low birth weight and prematurity. If you want to measure outcomes, I'd suggest you measure low birth weight for a lot of these. Low birth weight babies are what? 40-fold more likely to end up seriously ill or deceased than normal birth weight babies. Maternal depression, these are the usual suspects that you've heard about in the earlier presentations. Smoking, environmental health, connection to health care, particularly prenatal health care, preconceptual health care, and maternal life course, early pregnancy, and birth spacing. So a significant risk for subsequent infant illness or mortality is rapid repeat births. 6 months or less is pretty high risk. 3 years would be a nice spacing. So spacing these things out, this is what often people talk about as maternal life course. Early birth is a significant, early maternal age is a significant risk factor for virtually every medical and social ill you care to name. So we ran this, for example, in our data in Oklahoma, 60,000 first-time births. Our most common first-time birth was among mothers who were under 18 at the birth of their first child, had not finished high school, and were very low income. Within 3 years, 1 in 5 of those mothers had come into the child welfare system for neglect of that child. 1 in 5. That's huge. Our second group of mothers, most common, were 25 or older, had completed at least some degree of post-high school education, and had reasonably self-sufficient incomes. What do you think their entry rate into child welfare was? 0.3%. 20% versus 0.3%. So the point of this is that maternal life course matters. It matters for child neglect, it matters for child health, and a lot of other kinds of things. These are all non-specific causes. They cause infant injury and mortality. They cause a lot of other things in terms of social and economic ills. The specific things are relatively straightforward to figure out interventions matched to a specific thing. And you can embed these within home-based service models. You can embed them within OB/GYN care. You can embed them within pediatric primary care. You can embed them within hospitals. You can embed them within churches or community organizations. But they're fairly straightforward. Safe Sleep, have you guys heard of any of the Safe to Sleep program from NICHD? Back to Sleep is another program that's known of this. So these are relatively straightforward programs that are designed to prevent SIDS. Shaken Baby, probably one of the most popular programs is something called the Period of Purple Crying. Have you guys heard of this? It's an educational program about don't shake babies. If you're going to leave your baby with a boyfriend, make sure and talk to your boyfriend about don't shake the baby. Various other kinds of things like that. So careful selection of alternate caregivers and so forth. Car seat programs. I dialed this one up on the internet. You have one here in Ohio called Ohio Buckles Buckeyes. I thought that was kind of a clever name. So if people don't have car seats, they can't afford car seats, you give them car seats. So there's a lot of these very specific, concrete kinds of things, one-shot educational things that you can do for some of these specific causes. Congenital malformations, a little more difficult, but this falls into the whole preconception area, doing screening, counseling, genetic counseling for people that have certain inherited conditions and other things like that. Now, the more difficult part. What about the non-specific causes? And this is really where home visiting programs kind of come in. Because I'm not going to read all these, but these are some things that home visiting programs can address in the context of home visiting. Things related to low birth weight, maternal depression, environmental health, maternal life course, connection to health care, and all these other sorts of things. There's a variety of, you will hear about a variety of models, and there's a variety of names that get attached to all these home visiting programs. There are differences among them. There are differences in cost. There are differences in workforce and credentialing and training. And there are differences in the dose of services and a lot of other things. But if you go out, as I have done many times, and look at home visiting services on the ground as they are actually delivered, they have more commonalities than they have differences. So they have many, many similarities. But there's a variety of models, and they come from different traditions. Some of them come out of early childhood education, school readiness, things like early Head Start, parents as teachers, or hippie. You guys ever heard of hippie? Hippie was big in Arkansas. Hippie came out of Israel, and it's Home Instruction Program for Preschool Youngsters, hippie. And it's used a lot in Arkansas, and a lot of other states have statewide expansion of hippie. Parents as teachers. You guys heard of parents as teachers? It's again, a national model. A lot of it is based out of schools and run out of schools. Healthy Families America, probably, I'm sure you have several Healthy Families America programs in Ohio. It's probably the largest national model. Originally came out of Hawaii, and then was taken up by some national organizations, including Ronald McDonald Charities, and is now pretty much in all 50 states, and there's a number of Healthy Families programs. Nurse-Family Partnership is probably one that gets talked about a lot. I'm going to talk a little bit about some of these, but it comes out of a maternal and child health background, and the distinguishing feature of that is that it involves nurses, registered nurses as home visitors, which is why, see if I can get a pointer here. Oh, man. Okay, which is why you'll see this particular program. These are approximate cost per case. And if you want to look these up, you want to dial some of these up for yourself, there is a group of health economists in the state of Washington called the Washington State Institute for Public Policy. Google them. They do cost analyses as well as cost-benefit analyses on a number of programs. So a lot of these costs come from WISP, which is the Washington State Institute of Public Policy, and they have a group of health economists who do these analyses for the state of Washington government. But it's why Nurse-Family Partnership is a fairly expensive one, because it does use registered nurses, which are expensive. It also is a fairly high-dose service, so it tends to be expensive. Healthy Families America it's a very flexible framework that people can do different things and different contents under. I'm not sure what your local Healthy Families programs do, but they can vary, and they can vary also in cost. Early Head Start, you're probably familiar with as an educational program, fairly expensive. Parents as teachers, again, is a long-term program, often run out of schools. Hippie, relatively compact. This is one we've done a lot of work with in Oklahoma and also some countywide and statewide. We're working on a statewide implementation in the state of California. On this one is the Safe Care model. And part of the reason there's a lot of action around the Safe Care model these days. And part of the reason is it is a very compact model. It doesn't take as long. It is about 18 to 20 sessions. It is very structured, very curriculum driven, very skill oriented. So basically home visitors go in, they have a very structured protocol that they do about how to make homes safe, how to remove hazards, instruct parents in how to use a health manual. They provide basic health care materials to parents, teach them how to use them, teach parent-child interaction, and so forth. So it's very, very flexible in terms of who can deliver it. It's very concise in terms of the term, which means the cost per unit tends to be relatively low. The implication for that is that you can give it to a lot of people. So this is one we have scaled up statewide in Oklahoma, both with high-risk parents and within our child welfare system. People say, well, why are you doing this like most concise, lowest cost with your highest risk population, which is child welfare? That's because federal policy dictates child welfare has to be in a family's life and out of a family's life relatively promptly under federal law. So this means we need a service that can be completed in 6 months, not 2 to 3 or 4 years. So it's a fairly concise. And there's a lot of things happening with this one. Child First is one out of Connecticut. It is a parent mental health program that is very much focused on doing mental health kinds of things with parents that have serious problems. And Family Connections is another one that comes out of Baltimore that is more of a child welfare program. So you see there's different doses, different durations, different focuses. But if you look at what they do, there's also a lot of commonalities between them. What exactly do these home visitors do anyway? Well, there's a lot of things that they directly do, but they're not necessarily the most important things. For example, you may check a home for hazards and remedy those. Safe care home visitors will go through a house with a checklist. We'll go through it with a parent, have the parent do the checklist, look for basic child health hazards, things that might be electrocution risk, poisoning risk, fall risk, other kinds of things like that, and correct those. Teach parents how to monitor child health, know when to seek care, know when not to seek care. When do you go to the emergency room? When do you not go to the emergency room? Make sure there's a linkage to primary care involved. Set up healthy routines for infants and children. Breastfeeding and nutrition education are big parts of most of these programs. Some of them do developmental screening of children. Most of them demonstrate good child care skills, basic caregiving skills. So just think, if someone's a young mother and maybe is kind of clueless about how to take care of a baby, especially a sick baby, and they don't have a lot of people around them to help with this, someone who can come in, provide some skill education, let me show you how to do it, now let me watch you do it and coach you do it. These are the kind of things that home visitors do. But some of the other things that smoking cessation often gets embedded in home visiting, particularly the nurse-family partnership has very good outcome data on smoking cessation, and often screening for depression. But the most important things they do, I think, is that they function as part of a larger community health system for fairly high-risk families. So in other words, home visiting programs may be something that prenatal or primary care will link people to. Home visiting will also link people to primary care or prenatal care. They may link people to partner violence services or depression treatment services or drug and alcohol treatment services. We were talking earlier, pregnancy is a time in a person's life when it is a window of opportunity for health behavior change. We saw earlier in the smoking data how smoking tends to go down at the point of pregnancy recognition. So does alcohol consumption in most cases. These are windows of opportunity for positive health behavior change. So home visitors who are working with families and women at these particular points in time can capitalize on that and link them with services if they're needed. So in some ways, this is by the way, the child behavior problem management slide. You guys probably all recognize this picture. Those of you who are parents have probably lived through this particular picture on a number of occasions. Often when women have high-risk pregnancies and sick babies, they also have other children who are older children who may have significant behavior problems, and behavior problem management is something that home visiting programs can do or can link people to services for. So often there's a whole range of services that you think make communities and childhood healthier, and home visiting is part of this overall network. And often the programs are effective to the extent that they interchange back and forth with these other kinds of programs. Does that make sense? So they're integrated into the community, not both these formal services as well as what we'd think of as informal things within communities like churches, community centers, opinion leaders within neighborhoods and communities and so forth. So they work best when they're integrated into the community, based in the community, based in the neighborhood, and tied in with the local service system. So what I want you to encourage you to think about these systems is that they are part of an overall network of care and health improvement rather than thinking of them as standalone programs. There's not a lot one home visitor can do. So a home visitor can't be an OBGYN. A home visitor probably can't be a substance abuse treatment professional, may or may not be a depression treatment professional, or other kinds of things like that. So they rely largely on these kinds of other services. It is both a service that other community services will link to and a vehicle for triaging and assessing need and linking people back. And I was mentioning an example, for example, in our community, We have a rather sizable first-generation immigrant community from Mexico who migrated to Oklahoma City primarily for employment. And what we've been able to capitalize on is there is an indigenous community-based organization in Oklahoma City which happens to function very, very well. It's called the Latino Community Development Center. They are very well integrated into the local first-generation immigrant community. They are of the community. They are well known in the community. They're trusted within the community. They're viewed as a resource. You know, a lot of programs have difficulty getting referrals, getting clients in and keeping clients. They have problems terminating with them. Oh no, we don't want to leave. So, you know, but you're done with the program and we have other people waiting. So they're one of these kinds of agencies. So part of what we were able to do, and part of the University Medical Center partnering with them, was to base a primary care clinic for women and children on site at the agency in a part of Oklahoma City that is heavily first-generation immigrants. And we've managed to, thankfully, work with our local Medicaid, state Medicaid agency and others to fund some of this. So this allows the home visiting program, which this agency runs, which is, by the way, a Healthy Families model, and they also use a Safe Care model. They have two that they run out of this, to refer people into the primary care and OBGYN care. It allows the OBGYN to identify high-risk pregnancies and situations, link them back to the home visiting services so that they're integrated together within an agency that is of the community and trusted and has good ties within the community. So thinking of it as part of a network, if I've made that point, I hope. So if you think about the life course of morbidity, mortality, health, and welfare in mothers and infants, where in the course over time do these types of services fit in? And I think this is, again, comes back to some other things folks have talked about. Obviously, if you want to think about child health, you have to think about preconception care. And this can be things of physical health and well-being of young women. It can be things around family planning. It can be things around genetic counseling. It can be a number of things that happen in the preconception period that are important. Home visiting really doesn't target much in the way of preconception care. So if you're thinking about a continuum of services, this may be something where you have to think about the piece you develop to address this. There's a number of models that get involved during pregnancy and that work with women when they are pregnant. Nurse-family partnership is probably the best known. This is a dashed line because nurse-family partnership is not a particularly flexible model. It's one of the good things and bad things about this particular model. It has really good data. It uses nurses, so it's a very high level of expertise. It will only work with women who are pregnant with their first child. Only the first. After that, you're not eligible. And only during a certain window in pregnancy. After that, you're not eligible. So it's very limited in what it will do, but it does it very well. Healthy Families America is one that will work with women who are pregnant with their first child, their third child, their fifth child, and at any point in pregnancy or after birth or delivery. Safe Care is one that works primarily in infancy and early childhood. So these different kinds of models and the different content that they deliver are staged at different points. This is what we're developing in Oklahoma. We have a number of home visiting programs that are sort of knitted together to provide a continuum of care. On this axis is the age of the child. This is the point of birth, so this is the pregnancy interval. And this is the level of risk of the family. So these are for families that are very high risk in child welfare. This is a Safe Care model program. These are for families that are not in child welfare but have a number of serious risk factors, also Safe Care. This is a Healthy Families model that goes back all the way and extends forward. Parents as Teachers model, which is operated out of schools. And this is a Nurse-Family Partnership model. All of these are statewide. So they're in all 77 counties of the state. And this is a single point of contact, which we are calling Parent Pro. Free parenting support delivered to your door. And we hope to have this rolled out within the year, where it's a single point of contact to essentially assess and triage folks to whichever one of these programs fits, depending upon the age of the child and the level of risk involved. A number of states are doing this. The website, this should be on your handout, but the website down here from MDRC is they keep a list of the McVie sites around the country that are developing these single points of contact and triage programs, and giving some examples of those, and you can dial that up and take a look at them. So what about the outcomes of home visiting? Well, again, as you might expect from what I've said about home visiting, it is not an intervention that has a lot of specific outcomes. It is very much a rising tide lifting multiple boats type of service approach. So it doesn't have typically huge effects on any one outcome, but it affects a large number of outcomes. Low birth weight is one of the ones it has a really nice effect on. Child maltreatment prevention, relatively very small effect on child maltreatment prevention. Maternal life course, birth spacing, other things like that, typically fairly large effect on those. But so it has effects on a lot of things of injury reduction, low birth weight, does a really good job at linking mothers in with other available community health services. It doesn't do a lot about prevention of early pregnancy. The other thing it doesn't address very well are seriously ill infants, like infants coming out of the neonatal ICU with ports or feeding tubes or other things like that that may need much more specialized home-based kind of instruction and care. And this is kind of my area of work, is on implementation and scale-up of these kinds of programs. And the lesson we've learned over the years is that fidelity matters. Fidelity essentially means that what you build and what it looks like on the ground looks like the model, which normally, if you don't pay attention to this, it won't. When you keep fidelity up, typically the quality of the outcomes, the robustness of the outcomes tends to be maintained. So this has implications for, I know Medicaid people are here, this has implications for how you fund these programs. Typically the way a lot of social programs are funded, they're funded on unit rate reimbursement, where we essentially pay for volume. If you've been around the healthcare research community these days, you know the slogan is, we want to pay for quality, not pay for volume. And that's what this is all about. So essentially, if you want these programs to deliver the outcomes that they've been shown to deliver in the scientific research, you have to configure your reimbursement to pay for quality control, and not just simply pay for how many units you can deliver. A couple of other things about these particular programs. We're learning a lot about how they apply to special populations, how they apply across cultures, across ethnic groups, across socioeconomic groups, and so forth. There's been a fair amount of concern about this in the professional community. As the science has evolved, and we've begun to directly ask consumers about the cultural competency, the relevance, the engagement, the receipt of these services, basically what we find is that two main things. One is that benefits tend to be maintained equally across different groups. So in other words, programs that benefit one particular cultural or ethnic or racial or socioeconomic group tend to benefit them all and about the same. And secondly, if you ask consumers about the appropriateness and cultural competency of the service, they tend to be very highly rated. If you ask experts, they will have all kinds of concerns. But if you ask consumers directly, they actually tend to prefer these over some of the less evidence-based alternatives. So this is actually fairly good news that's beginning to emerge out of the research on these. So I think at this point we are about at the point of taking a break, and so if there's questions, this probably would be a good time to entertain them.
Do we have any questions for, yes?
I have one question, which is Healthy Start was not anywhere on your list. I know it wasn't in the first round of evidence-based models, just what your feelings were about where it fits, how it plays out in this.
Yeah, questions about Healthy Start. Do you mean the Healthy Start, the home visiting out of Hawaii?
I mean, that's a big component of the Healthy Start model, so it wasn't, that was a big issue that wasn't in the first, list of the fee, and I don't know if it's in this broader list, but I just wondered if you had done any research or included it at all in the work that you're doing.
Yeah, it depends on which Healthy Start you're talking about. There's a couple. Okay, Healthy Start has been subsumed by Healthy Families America. So that model essentially morphed into HFA. Or unless you're talking about the pediatric primary care-based Healthy Start, which is...
National Healthy Start, the National Healthy Start Association, is being used right now. Some of that is internal to Health Bureau.
Okay. Yeah.
You don't have any, okay.
Yeah, that's...
So we're going to, first, let's thank Dr. Chafin. I took a lot of notes. I took a lot of notes and put little dollar signs beside the organizations he talked about that had funding for things. So I'm not going to hold you accountable for what they do or don't do, but that was just, that's great information because we know we will need a lot of support and resources relative to this space. So we have one last, and we're not going to do this as a table exercise. We're going to put you on the spot, and we're going to do this as a group conversation around this whole area of home visiting. So you have a document in front of you. There are questions on this document. What I want to do is, one, get you to be responsive to the questions, but also if there are other thoughts you have as you listen to this presentation about home visiting, what we can do in our community. I learned a lot about what's available nationally. So one of the things I want to do is some homework on what do we do in this community and where and who's doing it, because that whole notion of the networking and linking that together I think will be important for us. So the first question, what do you see as the role and opportunity for home visiting to enhance prenatal care or birth outcomes in our community? Are any of you involved with organizations that sponsor or have a home visiting program? Oh, that you are.
Right. Well, I think as Dr. Chafin is aware, we have a nurse-family partnership that we run through the center. And then separate, which you made reference to, is also for our single ventricle patients. And we have a home visiting program from our nurses, but these are obviously a very narrow, specific group of high-risk kids who've got a significant problem there. But we often talk about the value of nurse-family partnership. It's certainly very beneficial for this particular group, which you mentioned. But I wondered, with your, we have some information on the patients we have, but the question I asked an earlier speaker, what's the treatment effect of home visitation? What is it? Because this is a group all about trying to reduce infant mortality in our community. And of course, all the things you mentioned are all marvelous things to provide. But what kind of impact do you think we might be able to expect on what our outcomes are?
The outcome, see if I can turn this. Is that?
They've got it.
Okay, thanks. The outcome I would look at is low birth weight. Infant mortality is a rare outcome, thankfully, which means that statistically it's difficult to detect an effect. So you look often for a proxy effect, something that is very strongly related to it but occurs at a higher frequency. That would be low birth weight outcomes. Nurse-family partnership probably has among the best effect sizes on low birth weight. Again, and it's part of a network of services. It doesn't do this all on its lonesome. But the low birth weight effect is large for nurse-family partnership.
Okay. So let's take a look at our second questions. Are there actions that our community could take to ensure home visiting resources are high quality and coordinated to impact families in targeted at-risk neighborhoods? This is one of those concepts that it's sort of like, am I looking at the wrong questions? No. Oh, God, thank you. Oh, like everybody's looking at me like I know what I'm talking about, so hopefully I've got the right set of questions. I think Dr. Chafin did mention this is sort of an initiative that you undertake. It sort of raises the tide on all boats, but we may not be able to necessarily, link it to specific outcomes. And so when we think about general health of women and having that nurse practitioner or someone in the home, are there actions we could take around home visiting to ensure that the resources are high quality and coordinated? I think Medicaid was one area that Dr. Chafin talked about that I made as a note. Didn't know if there were others that anyone else detected. Yes, please.
I'll mention one thing on that that we've had some, I think, positive experience with, and that is in forming partnerships between the delivery agencies and university-based expertise. So, for example, in our state we have Safe Care statewide, and that's run by our Department of Human Services through contracts with community-based organizations. They also contract with the university we have 2 people who are faculty experts and 2 people who are lead trainers in this area and who keep up with the latest developments and essentially are at the top of a quality control pyramid. In other words, they train and supervise in vivo coaches who go out on live home visits with home visitors, directly observe them with a checklist, give them feedback, essentially help them develop expert levels of competency. So essentially by linking to expertise at a university-based center and leveraging that expertise through a series of on-site coaches down to frontline service providers, we've set up a quality control system that we think, well, actually we have randomized control data to show that it improves outcomes by doing that as opposed to not having the quality control system. So whenever we had that data and presented it to the state, they opted to fund the quality control system. So I think that's one way. There's a number of ways you can do this. There's a number of models out there. One's called the Interagency Collaborative Team Model. It was just published in a Health Services Research Journal about 2 weeks ago that we were involved in developing. So there's a number of quality control structures that exist out there that you can take up that seem to improve the outcomes of these programs.
Okay, and you may have some comments on this last item. I mean, the question we wanted to provoke thinking around is, are there ways to link these home visiting resources to other community resources that address social determinants of health? So housing organizations, transportation, education, those kinds of issues, and tying these home visiting resources into driving changes in social determinants of health.
Yeah, this is part of why at the university we don't set up and run these programs. We run them through, ideally through community-based organizations that know their own communities and know what's there in terms of transportation, housing assistance, WIC, other kinds of things like that. So we're not the experts at the university. We're not the experts on the communities. The people in the communities are the experts on the communities.
And it's about getting them connected.
Yeah. It's about bringing them in and making sure you have those folks at the table.
Okay. Yes.
On that response, I think in real time, taking the show on the road and making sure that we are educating the community around issues on infant mortality task force. Dr. Long spoke to members of our Human Service Chamber of Franklin County Association yesterday. And the benefits of that conversation is I think we had an opportunity to talk about it from a community's perspective. And so there were certain content areas that we specifically focused on. So things like crime. We talked a little bit about mental health. We talked a little bit about housing. And so part of her presentation helped us make that connection that this issue around infant mortality is a community-wide effort and that we need to be integrated with our services and making sure that we're touching base with one another. So I think it's happening in real time, particularly in Franklin County. Yes, this is a shameless plug. I think members of the Human Service Chamber of Franklin County are doing a great job of collaborating and making sure that we are addressing these issues from a holistic perspective.
But your larger point is well taken. If we can get folks educated on the issue and around the resources that are available, and this is one of the resources, the home-based community care, and linking that back to not just the clinical, not excluding, but also the social determinants of health, you create a recipe for people to put ingredients together and come up with solutions that make sense for their neighborhood and relative to the resources that they have available. And then we can also continue to work on the larger issues of what resources don't exist that we need to create so we can add to that mix over time. Well, let's thank Dr. Chafin again for his time and his input. Thank you. So I think we're ready to wrap up. All right. So we've covered a lot of ground today. I won't go through all of the sort of individual recommendations and areas that we've come up with, but it's always good to recap. We've addressed smoking. Spent a lot of time on smoking and smoking cessation issues in our community, and we know that's going to be a real challenge, especially as we talk about low-income, undereducated individuals and women in our community, because that is sort of the, one of our speakers said, the last row to hoe, a tough nut to crack, all of those things I could come up with to describe it, but it will be critical. Prenatal care as well. So we also talked about prenatal care. We talked about the Medicaid strategies that are out there and that we could support, and also on the smoking, we talked about the lobbying effort that's needed, as well as continued education and with our young people, getting to them with these messages. And then we wrapped up with the home visiting discussion and getting a sense of how vital a role it can play, especially as we talk about overall health and being very clear about what it specifically can do and what it cannot do, so that we leverage it appropriately. And, sort of don't take and assume everyth's a nail and we only got a hammer and let's use it everywhere. Michael, anything else we should add?
Just a reminder to the task force that we will be in touch with you before the next meeting. Jesse or Julie or myself or Donna, either by phone or by email. We've covered a lot of material. We want to get some of your input individually on next steps and where we go. So between now and the next meeting, we will be in touch.
And let me add real quick to the public, if you made notes, please get those to our staff, because we want to collect those as well. So don't forget, don't take them home or key them in on your iPhone and then give us the paper, because it's proven to be very helpful.
Thank you again to all our speakers, and thank you for your time, Task Force, and we look forward to our next meeting.